Good morning, good afternoon, and good evening, wherever you are listening. This is another episode of the Two Lost Souls podcast. In today's episode, which is entitled Try the Veal, all about OCD, we have the pleasure of being joined by one of the leading lights in OCD research, someone who will need no introduction to all of you, and there may have been a hint as to who it is in the title of the episode just there. But before we get on to that, just to remind you that this is the podcast dedicated towards guiding you through your journey as a trainee CBT therapist. But we also are here for established therapists as well. As usual, I am joined in the therapy room today by the superb Michelle Sudbury. Hi, superb. Hi, Michelle.
Hi, Ravi.
Hello, how are you?
I'm good. I'm superb. Thank you.
I fear I rather backed you into saying that.
You did a little bit. Yeah. How are you? You okay?
Yeah, not bad. Not bad. I'm very excited about today's episode. A little nervous. Yeah, this is a biggie, right?
It is. It is a biggie. I'm very nervous.
Yeah. Well, let's hope that we don't make a fool out of ourselves and that,
I'll try not to.
Particularly because this could be headline news in CBT circles if we do today. So without further ado, I'm pretty sure people would prefer to hear our fantabulous guest rather than us discussing how our week's been. So without further ado, let's welcome into the therapy room Professor David Veale. So we have the pleasure of being joined in the therapy room today by the wonderful Professor David Veale. Professor, I'm sure you need no introduction, particularly for the more established therapists that are listening to us, particularly those therapists who are coming potentially towards the end of their training journey. But for those who aren't familiar with you or your work, how would you introduce yourself?
Well, I'm a consultant psychiatrist and cognitive behavioural psychotherapist, and I'm based at the South London Maudsley NHS Trust, and I mainly work in sort of tertiary care, so for mainly sort of severe treatment refractory people with OCD, BDD-related disorders, and I'm a visiting professor in cognitive behavioural psychotherapies at the King's College London.
Okay, and as you know, so we've brought you on today to help us explore the concept of OCD when it comes to, I suppose, the history of looking into OCD, your history of researching and working with OCD. Can you give us a little bit of background on how you fell into that and how you found working with OCD over the years?
Well, I guess I fell into it after I trained in what was behavioural psychotherapy many years ago with Professor Isaac Marks in the same department I'm in now. And I suppose I would really resonate with it because there was never a dull moment. There was always something different in each new patient I came across. And it's also tricky and challenging at times. And so I sort of quite like tricky, challenging cases. And then I got interested more in sort of body dysmorphic disorder, which got even more tricky, and emetophobia, which was also sometimes difficult. Health anxiety. So these are all linked and related disorders. And in many ways, there are very similar transdiagnostic processes going on. But it never seems to amaze me. And every new patient I come across, there's always something new I've learned from them.
Well, speaking of that, and speaking of that learning across your career, David, if you could go back in time and give your earlier self some advice, I suppose particularly when it comes to working with clients who have OCD, what advice would you give yourself?
Oh God, I'm going to have to go away and think about this one. I'm sorry. Actually, I shall tell you, never give advice to young people because they never listen.
As a mother, I would concur. It's very true.
They always go off and do their own thing anyway. So
absolutely. I have the pleasure of supervising a lot of our trainees that are coming through on the high intensity training programs. And I think one of the questions I get asked every single year is around why the chronicity level of people who have OCD is so high by the time they reach talking therapies. So my answer to that has always been a bit of a blag. And I think in my experience, what I've found from working with clients who have OCD is that it often comes with a lot of shame, guilt, embarrassment. And I've always kind of attributed that to for being part of the reason that people might wait so long before seeking support. It's rare in my experience to find a client who's at the early stages of having OCD, where the outcomes might be better. I was wondering what your thoughts were on this.
Well, of course, everybody wants to be able to treat early on. And I think there is a greater awareness. And I think that more people are seeking help, particularly in children and adolescents. But I haven't actually seen any data in terms of, we used to quote always it took 10 years before somebody got appropriate help. I don't know whether that's proving or not, or whether our treatments are just not, even if we catch them earlier, whether in fact our treatments are not preventing, further relapses or whatever. So I think part of the problem is, like in many problems, you can treat about a third and they never come back. About a third will come back at times of increased stress and go into relapse or whatever. About a third end up with some chronic severe problem. So that, are we doing better than that? I just honestly don't know. I don't know what the data is, but I think I don't have a feel for what's happening on the ground, to be honest, because I'm really working more in the tertiary severe treatment refractory services where it's always been bad.
Yeah, I think what I've noticed is I think for many students, it's a little bit heart sink, the first OCD client, because I think there's this expectation that they're going to be unsuccessful in treating them, because people are usually very poorly. And when we're trying to identify, suitable clients, air quotes, for trainees to work with, it's really difficult because it is usually, in my experience, clients that have lived with this for such a long time. It's very deeply embedded. And actually, the limitations of talking therapy can mean it's really difficult to have those successful outcomes.
Well, I think the limitations may be that it's often short-term therapy.
Yeah.
And as you know, it may be limited to 10, 12 sessions or something. And often patients need more time. And we know from even the research that compares, should we say, outcomes in OCD, say, to other anxiety disorders, it always does worse than, should we say, phobias and GAD or depression. So, it's not, I would always be optimistic with a client. And I often, and most patients can make good progress, but they may not necessarily be cured. And they may still be vulnerable to relapse in the future. And you do the best you can, but it may not be optimum, always the outcome. So, So I think I absolutely agree. I think it's important to be realistic. And the evidence is what I'd really love to see soon is the IAPT and talking therapies outcome data in OCD. I know it's sort of hiding there on the big data somewhere, but it's not yet been sort of published as far as I know. And it'd be really good to see.
You mentioned sort of nowadays, particularly working in the tertiary sector, more severe cases. I'm wondering actually, what are the different challenges you've had to navigate with that increased severity? How have you navigated them, aside from potentially extra time? What else is in your toolkit now that might not be in that IAPT or talking therapy space?
Well, the NICE guidelines talks about a higher intensity, and that includes both more frequent therapy or longer therapy, but also the experience of the therapist. And also knowing that it comes with lots of comorbidity. We see a lot of individuals on the autistic spectrum, ADHD, depression, PTSD, emotionally unstable personalities. So all these things are going to complicate and make life more difficult. So these things need to, the CBT needs to be adapted. The medication may need to be optimized. And, we don't cure everybody, but, our audits usually focus on the fact that we can get good outcomes in about 50% and 50% reduction of symptoms. So it's not bad, but it's going to be similar, therefore, probably to the sort of outcomes you get in talking therapies, but it's a different population. And I think talking therapy is also under a lot of pressure because, of course, the psychological therapies in secondary care are under pressure, and I think they tend to push down and sort of try to transfer their patients onto talking therapies. And so, you're under enormous pressure because as the psychological therapies in secondary care are often non-existent or got such long wait lists. So that still needs to be sorted out. And eventually it'd be nice to see more specialist regional centres in OCD and related disorders in secondary care. So I think there's still a lot needs to be done in the way that we've organised, say, eating disorders or whatever. It just takes such a long time to, improve services.
Yeah, sort of like trying to steer a cross-channel ferry, isn't it? Sometimes. I think Shell, one of your trainees, had a question about medication options. Is that right?
They did, yeah. So essentially, is there a role for medication when treating OCD? Is there ever? I think sometimes the anxiety is that, like with many other anxiety disorders, medications can become safety-seeking behaviours. And is that the case always for OCD, or do you think they have a good role to play? So that was the question.
Well, the evidence is that for people with mild OCD, in terms of function impairment, you should just be offered CBT. If you've got moderate functioning, then you should be offered a choice of either CBT or SSRIs, because the trials suggest they're equally effective. And in people with severe function impairment, should be offered a combination of the two. So I think it's reasonable when your client's not making as much progress as you had hoped, or the patient is getting more hopeless. It's certainly reasonable to signpost your client to your GP and to suggest that they discuss medication in addition to the CBT that's being offered.
And I suppose to follow on from that in a bit more of a broader standpoint, and I suppose take it back into the talking therapies realm as well, David, how do practitioners avoid creating coping strategies that just end up as more sort of socially acceptable compulsions? So, for example, there are some therapists, for example, that might teach clients grounding techniques as a way to manage their levels of anxiety. How do we stop that becoming just yet another form of compulsion that actually doesn't carry the stigma that some of these other compulsions do?
Yeah, it's a very good question, because the key to me is, what's the function of the grounding? Is it actually function as a way of avoiding anxiety and testing out your expectations, or is it a way of preventing you from dissociating, or something else that is gone beyond your threshold of tolerance, should we say? So in some people it can be helpful. I usually find that might be more helpful in someone perhaps who's on the autistic spectrum, who finds it really difficult to tolerate emotion, or emotionally unstable personality. But as you say, for most people, you've got to be a bit careful, because you don't want it to become a safety behaviour or another ritual that functions as a way of avoiding any emotional testing out your expectations. So it's a good assessment is really important, I think. And really, I think one of the key things is often to be able to join your client client in the moment and actually test things out and do things with the client in the session to actually observe, what it is that they're doing and are they able to actually do what it is that you'd like them to do. So I think always, if possible, don't just talk, but do. That was my disappointment, I think, when it got rebranded as talking therapist, because there's not enough emphasis on the doing.
Yeah, I completely agree. I think for quite a lot of anxiety disorders, actually, I find that the power is in the actually let's get out of this chair and do something rather than talk about doing stuff.
Yeah.
So I'm in complete agreement there. And I suppose thinking about, managing that anxiety, I'm wondering what advice you might give to therapists to help manage their anxieties while guiding clients through ERP. For example, ERP is quite a challenging a form of treatment for the client, but also watching someone go through that can be quite a difficult thing to do. So I'm wondering what advice you might give to therapists in terms of actually being able to contain their own feelings as they go through that process.
Yeah. I mean, I suppose the first thing I would say is to do your own exposure and behavioural experiments in terms of things which are challenging. So I can always remember 20 years ago, I can't remember whose workshop it was. I think it was a behavioural experiment workshop. So I set myself a task of going into the park and picking up some dog poo, rubbing it in my hands and tolerating the disgust and the anxiety. And it was quite an interesting experiment because even when I scrubbed myself with it, and I'm not suggesting, I've never asked a client to do this, but even when I was scrubbing my hands, as it were, it still felt contaminated. And I was wanting to sort of hold my hands out like a surgeon, as if I got gloves on or something, even when it was objectively clean. So whatever it is that you don't want to do, really try it out yourself and see what it feels like. So that's, the experiential part is, I think, an important part of your training. Did you get that as part of your training?
Yes, I did.
Good.
Well, we did, from my training, we did behavioural experiments, but I can't say it was anything that vivid, I have to say.
No, it was not that extreme.
Oh, that was an extreme.
But I was very lucky to have had a manager who was a huge fan of, hands down the toilet, licking the shoes, would really encourage that. I can't say it's my favourite thing, I'll be completely honest with you. But I absolutely would promote that with trainees, with CBT therapists, because you're absolutely right. We had a situation in supervision just last week where the therapist was kind of demonstrating or showing their own level of disgust. It kind of almost colluding a little bit with the therapist, with the patient, because they also thought that, not cleaning a work surface and then eating and prepping a meal was just, unforgivable. And it was just such an interesting conversation to kind of watch their process and how impactful that is going to be in the therapy room. It's really, really interesting. And I always worry that I'm going to get in a battle, a bit of a kind of like an argument with the client or even with the supervisee. So it's a hard one to promote, isn't it?
Sure, but you must be prepared to do the so you're asking your client to do your stuff, whether it is magical thinking and trying to kill off your parents or whatever it is, or whether it's using, as you said, a Ouija board or eating crisps off the toilet. These are all standard good exposure experiments, and it's very much in the mold of anti-OCD or overlearning. Yeah, so it's not, as you know, just about doing the things which you're avoiding or doing the things which you value, but about overlearning. And these are the most powerful experiments. So it's having high expectations. You may not get your client to do these things, but if you can demonstrate them and be able to show that actually it may be abnormal and the man on the clap on omnibus or whatever it is not going to do it, but actually they're very powerful interventions for treating OCD, even if you think it is abnormal. It doesn't really matter. How do we contain the therapist's anxiety? Well, I think if you're going to work with clients with OCD, you do need to be enthusiastic and to be able to model these sorts of tasks. I think if you're really, uncomfortable about them, I'm not convinced always that you're the good fit with working with OCD clients. Because often, clients will say to you, well, even my therapist said that was going to be disgusting, or this, that, and the other. That's not helpful. Or, you can expect it from a relative or something like that. But I think we need to be enthusiastic, have high expectations, really make sure the client understands the rationale, the principles of overlearning, and, that your client is not going to come to any harm. I've never seen really anybody come to harm from doing exposure tasks. Sometimes the exposure tasks is not necessarily appropriate. I'm thinking perhaps of someone with a vomit phobia, and I've seen people who have been vomiting repeatedly, deliberately or something, and it just convinced them that they should never vomit again in their life. So I think there are things that you can learn from that are not necessarily appropriate, and picking up dog shit in your hands is not appropriate probably. But sometimes I get a bit. There's a few tasks I can remember thinking, oh, is this such a good idea? I can't remember the context, but there was a Muslim, for example, a Muslim man who thought it was a good idea to urinate on the Quran as part of an exposure task, because he was a very deeply religious man or something. I can't go into the details now, but I just thought, oh, is this such a good idea? So there are things, sometimes, in general, I have to say sometimes when clients come up with some exposure tasks, they're not always helpful. So you really got to think through sometimes, what is the purpose of this? What is it you're going to learn?
I think that's a wonderful example, actually. Can I ask how you sort of navigated that? Because that seems quite the quandary.
Yeah. The problem is, of course, it's going to lead to different opinions from different people. And so I think, someone else will say, oh, yes, that's an excellent idea or something. And so, of course, unless you're working as a team, or even if you're not working a team, inevitably you're going to come across other people, and it will come into folklore that such and such said it was not a good idea. So you can easily go down these rabbit holes. I think if you're too led by your client's enthusiasm for doing certain things.
Something that had occurred recently was a therapist who was treating a client who had contamination OCD, and was really finding it difficult to separate that from the religious cleaning that they were doing, particularly of their arms, hands and arms. Navigating that was very challenging for the therapist, and they were really struggling to help the client to differentiate the function of both of those things, and struggled a lot with creating exposure opportunities. And I'm wondering, how do you navigate, or how do you manage that?
Yeah. I mean, I used to think that it was helpful to involve a religious leader. Whether it was an imam or a Jewish member of the community or something.
Yeah.
And then I realised that actually it depends entirely who you ask, because it depends on how orthodox they are often. And if it doesn't give the right answer to your client, then they easily get dismissed as being too liberal or whatever it is. Yeah.
Yeah.
It's a very difficult thing to navigate. But as you say, hinting there earlier, it's always really trying to understand the function of it and what is normal. And usually you can find out what is normal, from asking around the religious, not necessarily leaders, but other individuals, who in terms of what would be normal practice for this particular, what's normal washing. and the function of it. Because, in OCD, it's much more about, to feel comfortable, to feel right, to decontaminate myself, and so on and so on. And so, of course, that's what you can target, as opposed to a particular religious ritual, which is done in a particular context at a particular time, as opposed to something which often is then being abused, in many ways.
Yeah.
So you're absolutely right. You've got to really have a clear columns of what is my OCD and what is a normal religious practice.
Yes.
And I think it is a very difficult thing to negotiate and to navigate, because you want to be not offending the religion or being culturally appropriate. And it's certainly more difficult, isn't it? It's going to be to doing any anti-OCD tasks and the sort of thing I described before that I wouldn't come up with myself. But I think one of the things that I'm just not sure about is I know there's all sorts of books and podcasts, all sorts of things now on how to treat, shall we say, a particular religious type of OCD, whether it's Islamic OCD or whether it's a Jewish OCD and so on.
Yes.
And I'm not entirely convinced, because there's the same processes are going on across these religions. And often I wouldn't really get involved in the content of it. It's the processes that are important, whether it's to do with a sense of contagion of one thing touching another, or whether it's the magical thinking and things like that. It's just a different content across the religions.
Yeah.
And I think I'm focused more on those processes rather than any of the content.
A slight departure from that. I was wondering, actually, and this might be a benefit for individuals who are perhaps slightly early on in their training, perhaps individuals who are maybe encountering clients experiencing symptoms indicative of OCD without having been taught the kind of module content on it yet. And I'm just wondering about Puro, which has been a term that has come up quite recently. I'm wondering what challenges that has posed to the therapeutic process, what challenges, I suppose, what's changed in potential avenues for treatment as a result of Puro and the differences.
Well, the term Puro is, of course, something that's been very user-led. It's not something that's been developed in either academic circles or by therapists. And it refers to pure obsessions. But of course, they're not actually pure obsessions, because people are 99% always responding to them in some particular way, and they have a particular meaning. So it's no different then from any other type of obsession or rumination, which is predominantly in one's head. So there may well be particular meanings, and often the classic ones being this intolerance of uncertainty, the overinflated sense of responsibility, the magical thinking, the way that you think that you can transfer one piece of contagion from one thing to another. So it's all the classic types of appraisals that go on in OCD, and all the classic types of ways of responding, whether it's trying to avoid and suppress and get rid of those particular thoughts, or to neutralize them, or to undo them in some way, and to mentally wash them, or to mentally review and check what it is that you might have said or done, or to try and imagine what's going to happen. I mean, it gets complicated, doesn't it? In the sense of trying to work out exactly the different pathways that individuals take in their head. And it's not something you can actually see. So it's a really important assessment in terms of understanding when an intrusion, and don't forget the thoughts and images and doubts come into your head. What exactly does it mean, and what exactly do you do with it? In terms of whether it's avoiding, suppressing, neutralizing, mentally reviewing and checking, and so on and so on. So it does get complicated, and I think it's often underestimated by clinicians because, people can be spending hours very self-focused and just ruminating all the time, and can be very disabling, in terms of the impact in the person's life. But I think often we forget there's often avoidance of particular triggers. So, let's say they're preoccupied by paedophilia or something, they're, bound to be avoiding situations, places where they might be alone with children. You can always think of avoidance as coming in there as well.
The last question that I had from the trainees was around developments within OCD and what you feel the most exciting upcoming developments might be for the treatment of OCD, either within talking therapies or wider fields.
I think we are frequently targeting around the edges. There's some new, let's say in contamination, having a better understanding of the avoidance of the feeling of disgust, and moral contamination, the way that we get a better understanding of that. And we get a better understanding of things like relationship OCD in terms of doubts and fears about what you have about your partner and so on. And we get better understanding of postnatal OCD, perinatal OCD. So there's lots of things around the edges, I think, that all contribute to our better understanding and treatments of OCD. Have things changed very much? I am broadcasting a stone's throw away from where some of the original work was done in Muswell Hill, in some of the first times when they first started doing response prevention. And it was an inpatient ward where in the 1966 or something, Ted Chesser and Myers were trying to help people to resist their urges to wash or to check and so on. They were quite radical in those days. I mean, they would turn the water off in the rooms and all sorts of things. But, if you look at some of those original papers, they were thinking quite cognitively in those days because they were wanting to help patients to test out their expectations and to see whether, in fact, the distress lasted as long as they thought, or whether, in fact, the bad things happened, whether they could tolerate it, and so on. So we, I think, often change our language and change the models slightly, but has it changed fundamentally? Oh dear, I'm not really sure. Since 1966. So I think it has improved. I think outcomes are improving, but it's, the fundamentals, are really there since the early 60s, really. Well, the biological psychiatrists getting very excited about all sorts of things in terms of possible new medications like psychedelics and things, which may help you take away. So this is for psychedelic assisted CBT in psychotherapy, which could be quite an interesting development because it seems to help take away your sense of self. And, in 10 years' time, will you be giving your patient your psilocybin or MDMA or whatever it is? This is actually something that was predicted in an interview I had with R.D. Laing when I was a medical student. So he said, in many years to come, you will have doctors who can prescribe these drugs and, and so on. So it's pretty slow. I think that's probably one of the most interesting areas to come up. And it may help those people with severe treatment refractory. And we'll see, because, it's becoming legalized in Australia and some places around the world already. So if you're interested in that area, I would read the books by David Nutt and so on, who's been looking at this for many years. Yeah. I'm not convinced there are other drugs on the market which are coming up, which are going to really help much more. We haven't really made any improvements on SSRIs, but they are not really acceptable to all patients because of side effects and so on. But, they can be effective. But I don't think anything else has really come along and bettered them yet, or on the horizon. And people get interested in things like RTMS and transcranial magnetic stimulation. But again, a lot of these things are pretty weak treatments, it seems. And so there's nothing that's really made me think apart from the psychedelics.
That is really interesting, though. I think that's definitely something I'd want to read more about. And I also thought it was great when you talked about, exploring OCD within different demographics. You mentioned kind of the work that happens with clients with kind of neurodiversity, neurodivergence, and obviously we're in a different landscape in that area at the moment, aren't we? That's taken off massively over the last few years. We're exploring that in a completely different way. So I think that's quite exciting in itself. I think for us, probably at this level.
But
yeah,
be aware that the trials that have been done in adults are not that good, in the sense that, in terms of CBT versus anxiety management, it's not much better than anxiety management. So that we've still got a long way to go to actually adapt our CBT to help people with ASD, and to be very clear about, well, what's the ASD and what's the OCD? Really, again, have a clear distinction between the two.
Yeah.
And
more research, more investment in that then,
I think it is tricky, definitely more difficult.
The final question that was passed to me from my service was around the balance between cognitive and behavioural work as part of a treatment plan for OCD, and I suppose asking what that balance is, and I suppose how does one find the most effective balance for their client as they're finding their way through treatment?
Yeah, I wouldn't artificially divide the two. Look, your client is not going to just engage with the behavioural work until they've really got a good understanding of what the problem is and what's maintaining it and what they need to do. Really have a good understanding of the rationale and what is keeping the problem going. I think that for some clients, they get it intellectually and they know what they need to do, but there's quite a big discrepancy between their head and heart. Yeah. And so I think that's, again, another challenge for us, to be able to help people to take that leap of faith and be able to do things which are the old brain or whatever is telling you not to do because it's dangerous and threatening and everything else. So I think that's one of the most difficult things. I think there's some interest in trying to view often compulsions as habits and recognizing that they just develop a life of their own. And it's very important sometimes to be able to increase awareness of when you're doing a particular compulsion, because often these things are just done so automatically, you've just gone down a rabbit hole before you realize it, whether it's a mental compulsion or whether it's a physical compulsion. And so, the sort of things you might use in habit reversal and so on, things like increasing awareness of the behavior, and things like using a tally counter and really a sort of diary, more of the context and when you're doing it, and understanding the context in which you're doing it can be very helpful. So you're increasing, so you can then try to choose whether you're going to go down that rabbit hole of doing that particular compulsion, or whether you're going to try to either resist it or to spoil the compulsion in some way. I wouldn't say there isn't any difference between the two, in the sense that, behaviors have cognitive aspects. So, for example, we're going back to the compulsions again, it's very important to try to understand the termination criteria that's used for the particular compulsion. Often it's things like, when I feel comfortable, when I feel right, and these are somewhat problematic, of course, because they are impossible to achieve or going to be causing lots of problems in the long term. And as I said, when you're doing behavioral tasks and exposure, there is a cognitive component, because there are exposure and behavioral experiments are like two sides of a coin. On the one hand, you are tolerating the distress, But on the other hand, you're also testing out your expectations and theory, whether it best fits with theory A, theory B, and whatever. So, both cognitive and behavioural are intertwined all the plays up.
Yeah. Well, I'm intrigued actually, there, David, because during what you said there, you spoke about that discrepancy between the head and the heart, particularly in some clients who sort of know that they need to change their behavioural patterns, but the heart stops them from doing so. And I suppose there's that link with what we said earlier of, as part of the therapeutic process, don't just talk, do, which is a really powerful tool that we have in our toolbox as part of a therapeutic journey. And thinking about how the world has changed, been forced to change, I guess, over the past few years, I'm wondering how that can be effectively carried over to a remote medium, I guess, where clients have to be a bit more independent and a bit more courageous, I guess, in terms of actually going through and engaging in that exposure work.
Yeah. Well, you can still ask your client to put their phone or whatever it is around their neck so you can see what they're doing and get them to walk around and do that particular task in front of you and get them to talk through what they're doing. Yeah. So it is possible, but you need to adapt things. It's definitely doable. But as you say, I still prefer to see someone face to face, to be honest. And I know I'm very dubious that you can treat people with OCD by text or whatever it is, which I know is occurring in some talking therapy services. I'm just not, other than the most milder cases, I'm just not convinced.
Well, I'm really interested. I think that's a really good point, because Shell, and I'm not sure if all the listeners know this, but Shell does work for a sort of text-based therapy service on the side. And I'm just wondering what you've encountered in terms of treating OCD via text, what extra challenges there've been, how you've navigated them, and what the landscape of that's been like for you.
Yeah, so I do work. I do typed therapy as well. It's another little side gig. I've never had to treat an OCD client using that, so I'm no good to you, Robbie, I'm afraid. I wouldn't. I don't think I'd want to. I think the modelling that you described earlier. I'm a massive believer that you kind of show what you'd like to see, and if we can't do it, then to ask somebody else to do it is very unreasonable. So the modelling I'm a big fan of, and it's just not going to play out over text or typed therapy. It just isn't going to work. And even with the most creative of therapists, I completely understand that, over video you can do things together. It can still happen in that way. But yeah, anything more remote than that, I think you're going to really, really struggle. I wouldn't like to do it. And I don't think I'd like to be on the receiving end of it either, actually. As a client, I'm not sure I'd be a fan.
And I don't think we've got any data on it at all.
No, probably not. No. And obviously it's become much, much more popular, but what's the reason for that? It's a little bit like why all the social anxiety clients are asking for telephone appointments. It's not because it's the best treatment option. It's because then they don't have to kind of be on a screen or be in a room with somebody. So we know that we're just essentially colluding with and enabling some of these behaviours in a really unhelpful way. We're not using evidence-based in that. And that's what we're all about. We need to be using evidence-based, don't we?
And the logical extension of all this, of course, is that there would be an artificial intelligence assistant who will be treating our clients. Yeah. Maybe, I don't know, 5 years, 10 years. I mean, it is extraordinary, the pace of change at the moment.
Yeah, it's a very good point. We'll all be replaced by robots.
See, I don't think we will, if we know there's such enormous demand.
Yeah, well, that is also true.
Yeah. So I think that, the first thing it will take over more is assessments, and it has done that to a certain extent. There are artificial intelligence type assessments going on, chatbots and things in therapy services, and they can come up with a clear description of what the problems are and what you need to target and so on. So the next step would be more interventions, I think, but I shall be well retired by then.
I was going to say, actually, we're speaking of great technological advancements, and this isn't related to AI in any way, but if people navigate to veale.co.uk, I believe they can see a little avatar version of yourself. Isn't that right, David, answering frequently asked questions about particular disorders?
Jack, JAAQ, just ask a question.com or whatever it is, in which we were filmed answering questions. So there's about 100 different types of questions you can ask on OCD and BDD, and other colleagues like Paul Gilbert has been doing one on depression and every disorder, as well as all lifestyle choices and so on. And even more important is that there are users on there as well, so you can ask the user about their experience of OCD or depression or whatever it is. And some quite well-known people, whether it's of psychosis or whatever. And I think it's a great resource where individuals can actually get to the questions they want answered and get a response and, explore it further.
Yeah, Jack. Amazing.
I'm really amazed by the little interlude bits as well. I think after a while, if you don't click on a question quickly enough, I think I see you checking your watch a few times. That was quite wonderful.
You see, actually, when it was first developed, you could actually ask it verbally over your microphone, and they would translate it as you go along. For some reason that's gone now, and you have to actually type it in or use their standard questions as such. So it may well come in the future where you could actually literally talk to me beyond the grave when I'm dead, and you can still talk to me.
Wow. That's amazing. Totally amazing.
Reminds me of another interest I have in death anxiety, which often cuts across in OCD, health anxiety, and so on. We're having lots of fun still with that.
So you really do go for all the complexity.
Weird and an easy life. Someone told me it was often the weird and wonderful things. No one else dares to go and sort out.
No, that's a nice way to describe it. I like that. Yeah.
I think it's important to say as well, I'm really glad that we were joined by the real life Professor David Veale today. And I suppose just another question, I suppose zooming out slightly from the focus on OCD. And I was wondering if, and I'm conscious you said earlier that, don't give advice to young people because they don't listen. But I'm wondering if you had any advice for any therapists who are in training who are just beginning their journey just after training. What advice could you give them? What helpful hints do you think might help them along the way?
Well, one of the things that I've got more interested in lately, and I think I should have persisted, actually I was thinking about my younger self, is an interest in lifestyle psychiatry, psychology, and so on. And this is mainly about improving sleep, diet, connections with others and connections with nature, activity, yogas, and all these sorts of things, which, is building an evidence base for being able to perhaps prevent and treat a number of different emotional disorders. And I'm sure that it's going to have a part in the jigsaw to play. It's mainly so far been evidence-based more in depression, less so in other conditions. But, I think it's something that as therapists we tended to ignore a lot of. That it's very difficult, though, isn't it, in terms of actually helping people to change their sleep pattern or helping people to eat healthily and improve their gut microbiota, helping people to really overcome their loneliness and so on. So I'm hoping that we're going to see get a lot better at being able to develop interventions to make these effective life changes, right from the very beginning. Because I just got a feeling that there is something in this and that there is more that we can be doing there. I mean, you look at the junk and the obesity and the inactivity and the poor sleep and all sorts of things in young people. And just simple interventions and trying to really help support them to do some basic things can be very powerful.
Briefly, before we draw things to a close, David, where can people find more about you, more about your work, any online resources that you'd be able to link people to where people can find out more about you?
Well, I've got a personal website, veale.co.uk, where you can find most information, all sorts of things I've been interested in, from wake and light therapy. You know about wake and light therapy? This is another little area which I'm interested in. That's a rapid treatment of depression by sleep deprivation and being able to advance your phase of sleep, and bright light therapy. So we were able to get one trial about 50% of people better after about a week. So these are early days again, because they're very small. They're small trials, but it's very difficult.
Where do I sign up, David?
My fantasy, here's my fantasy, okay, is to, if some philanthropist will help me do it, is to have a massive night walk in London, say, where, a lot of people go off on these night walks to raise money for cancer, this, that, and the other.
Yeah.
Actually, we could do this for depression and have a night of sleep deprivation followed by phase advance of your sleep, followed by bright light therapy in the morning. So it's like a control-alt-delete in terms of resetting your circadian rhythm. And the problem is, unless you do the other bits and pieces after the sleep deprivation, there's a very high rate of relapse if you do respond. So it's been around, since the 60s, 70s, but it's very still under research. But there's no money in it, of course, because there's no drugs or anything else. So sorry, that was just something I threw in.
Not to, well, on the off chance that any generous benefactors are listening, or anyone linked to a generous benefactor is listening,
the idea of thousands of people with depression improving over a week.
Yeah,
that
would be great. I'm sure we'd try to put our name the Two Lost Souls Night Walk for depression. That sounds great.
I'll be there. I'll absolutely be there. The only other ones I've seen are the ones where you've got to do it in your bra, and I don't fancy those night walks.
The cancer.
So I'll come to that one. Yeah, the cancer. The bra
walk. And it's very successful. And I actually became a volunteer for it one year just to see how it's done. It's fantastically organised. But I just think it'd be interesting to do for depression.
Oh yeah, we'll come to that definitely, 100%. Sounds great.
So I got distracted. I think I've got a bit of mild ADHD sometimes. I got distracted. So on that website or on the KCL Pure website, you can find a lot of the papers you can download. So in OCD, we've got things like, particularly keen on things like risk assessments and doing a proper risk assessment and not sending people like paedophile OCD and so on to safeguarding and all sorts of nonsense. And other stuff like that. We've got a book course on overcoming OCD. Yeah, that's enough.
Well, fantastic. Well, those are really helpful resources that I would also recommend listeners check out, no matter where they are on their therapeutic journey, be it in training, be it as more established therapists who just want to familiarise themselves a bit more with OCD and its treatment. David, thank you so much for coming on today.
Thank you.
This has been absolutely amazing. We hope you'll come back again sometime soon, obviously, as well. If the night walk does work out and you'll have to come back to promote it at some stage, give us a shout. We'll always be happy to have you on again. Thank you so much for coming by. So, Shell, what did you make of that?
Oh, I'm proper fangirling. He's just brilliant. The knowledge and such an interesting man to listen to, and his expertise in this, in not just that area, but the level of complexity that he's kind of researched and wanting to have these better outcomes for clients who are living with really distressing and debilitating disorders, to invest yourself and make that your life's work, I think is just magnificent. I'm completely in awe of him. I thought he was gorgeous.
Oh, definitely. I think his passion for the subject is also quite
Hmm.
contagious as well. I found that to be very affirming, actually. I think OCD is one of those conditions where it's sort of in this strange sweet spot where it comes along often enough to obviously need quite a repeatedly high skill set to deal with it, but it comes round
Yeah,
seldom enough for it to be a challenge each time it does come up, because you've been treating loads of different things in the
yeah.
meantime. And I
And
think
it's
that
so nuanced, isn't it?
yeah,
OCD, because it's so multifaceted, and you could be dealing with a kind of myriad of presentations that all make up this one thing. It's kind of like an umbrella term for loads of different things. I think it can be really overwhelming for new and for kind of more established therapists to really think, am I doing the right thing? Have I got this right? Am I giving the best treatment that I can give here? But what David's offered there today is coming back to, let's simplify all of this. Let's come back to the function of why people are doing the things they're doing. You don't need to worry quite so much about the content. And I'm a massive fan of that. I would always promote that. So I loved hearing that from him.
yeah, and I think for any trainees listening, that also helps you to work very transdiagnostically as well. Sometimes
Mm.
it doesn't, the label on the tin doesn't really matter a lot of the time. If you're breaking it down to, okay, what's the function of this, that's what counts.
Yeah.
And I think, I mean, a couple of useful takeaways from that interview for me. One, in terms of exposure work and the modelling, I think you mentioned as
Mm-hmm.
well. I think even doing that remotely, I just had some thoughts in my mind of times where I've been doing exposure work with clients, and it only just hit me in this interview that, hang on, why didn't I lock myself in my bathroom just to show that it can be done?
Yeah.
And
Yeah.
I think the other key takeaway, and this is something that I think I knew, but I never put it into quite succinct terms as this: don't just talk, do. I think that's a really powerful thing when it comes to talking therapy as we know it today, and a really powerful change maker for the client as well.
Yeah. 100%. It's so interesting, absolutely so interesting, and I completely agree. I know I've shared on here many times, my own experiences of mental health, and having had panic, not OCD, panic, but knowing that actually, if I hadn't been doing the things, I could talk about it till I was blue in the face. I had to do the things, and having somebody brave enough to kind of model that and do that with me, to show you that it's safe, to show you that it's okay. It might not feel comfortable, but you can do these things. And OCD is in exactly the same vein, isn't it? It's you're not supposed to enjoy all of those experiences. Rubbing dog shit in your hands is not something anybody does for pleasure. But actually, what was the message? And the message is, you can do it. You can cope with the discomfort and the distress and the distaste that it leaves. You can cope, and that's what CBT is about in so many different ways, isn't it? In so many different presentations. So
Yeah, totally. Admittedly, on each of the 3 occasions in this recording today where we've referenced rubbing dog shit in our hands, I have had a little shiver go up my spine. So clearly that means I know what I need to do in about 15 minutes from now.
yeah.
But
Well, you've got a
yeah,
dog. You're going to have lots of shit about.
well,
I mean,
well,
if anything like my dogs, I clear up, I don't know, about 97,000 shits a day. So you should have ample opportunity to go and
well,
do
there we
that, I
go.
think,
And
Robbie.
and imagine the money I'll save by not using a bag, eh? Well,
And
so
the environment.
and the environment. Oh yeah, sure. That was my first concern. Yeah, that's true.
Yeah, and that, yeah.
Yeah. So obviously, an absolutely superb guest that we had on today. Every guest I think we've had on
Immense.
this show so far is absolutely superb. And
Yeah.
if there are any other topics that you would like to hear us explore on Two Lost Souls, if there are any other guests that you might like to try and see us press gang into being a guest on the show, let us know. Drop us an email at twolostsoulspodcast@gmail.com, or hit us up on X or on Threads or on Instagram, TLS_pod on those on those social media websites. We aren't always the best at getting back very quickly, but we do what we can, and we do take all your suggestions on board. So keep them coming through, and we will see you very soon for another episode of Two Lost Souls.